Yeah. So time is 7. Good evening, everybody, and welcome to the Uromet 11 that is focusing on pediatric urology mock vivas. Welcome our today mock examiners, Dr. Sanjay Abegunawardena and Dr. Kanya Edrisinghe. Warm welcome, and I appreciate their hard work of making the case scenarios and coming on time on a busy day. And I'm also welcoming Anurudha sir on behalf of SLAUS. Today we hope to do at least about 6 scenarios. If time permits, we can do more. We are starting with the first scenario. The first scenario will be, the examiner will be Dr. Sanjay Abegunawardena and and the candidate will be Dr. Taha. Taha, are you ready?
Yeah, ready.
So the time I will time, so it will be 10 minutes. Sanjay sir, are you ready?
Can you hear me?
Yes, sir. Yeah.
Okay. All right. Yeah.
Is it possible
okay.
to
share
hold your video as well, sir? If possible.
Okay. Yeah.
Okay.
Right?
Yes, sir. Okay, sir. That's fine. Yeah. Excellent. So, right. Taha will be the candidate, and Dr. Sanjay sir will be the examiner. Right. So, shall we start? Time starts.
Can you see my slides?
Not yet, sir.
Is that, can you see it now?
Yes, sir. We can see now.
Okay. Shall I zoom on then? Okay. Is that visible? My slide is visible now?
Yes, sir. Yeah, visible. Sir.
Okay. So we'll start. It's a referral from the obstetrician. Mr. and Mrs. Fernando is referred to you by the obstetrician with an antenatal scan of the baby showing a left-sided hydronephrosis. Okay. So, Taha, is that right?
Yes, sir. Good evening.
Yeah. Yes, Taha. So, do you like to ask the parents anything, or do you like to know any details about the parents? It's a couple with the antenatal scan of the baby having unilateral hydronephrosis.
Actually, I would introduce myself, and then I would ask a few questions regarding their previous pregnancies.
Okay.
And any previous events of any hydronephrosis, previous pregnancies, and then any risk factors for developing this hydronephrosis. My possible differential diagnosis would be either it can be PUG obstruction, megaureter, VU reflux.
Yeah.
So I would like to ask any history of diabetes mellitus, oligohydramnios, any fetal abnormalities in the past, any miscarriages in the past, and any family history.
Yes. So there is no, this is the second child, the second pregnancy. And the first child is a healthy 3-year-old. The POA is also an important thing. So they're 30 weeks pregnant. And the antenatal scan was done last week. And it's a male fetus as well.
Okay.
So, okay. So
my the possible impression would be unilateral PUG obstruction or PUG dysfunction.
So how would you? So the parents are very anxious as usual. I mean,
yeah, it's a bit of a stressful condition because, as you said, parents are a bit worried.
They have these questions for you. Yeah, so they want to know what's wrong with the baby.
I would say there is a dysfunction or the dilatation of the upper part of the renal tract. Anyway, we have to follow up with this baby with the follow-up scans, and possibly after delivery also we have to do repeated scan.
Okay, so they want to know whether they need to do, whether you have to do anything urgently about on the baby? Do you?
Yes, at the moment, sir, nothing needed to be done, because even though if it is a PUG obstruction, there is spontaneous resolution,
Yes.
depending on the AP diameter. So it is just monitoring for the time being, but I will make sure that they attend the follow-up scan, follow-up clinics, and then I would make sure that they.
Yeah, yes. They want to know whether if you leave it like that, now you said there is a possible obstruction. So if the obstruction is left untreated, can it deteriorate?
It depends on the severity of the obstruction. It goes with the AP diameter of the pelvis, because natural history been studied by the paper by Dylan, because there is spontaneous resolution when the AP diameter is less than 10. So it's a bit of a question of discussion. I'll make sure that nothing needed to be done at the moment, but should be followed up.
They've brought, they have gone through this on the internet themselves, and they have found that, in some centers, they do antenatal interventions. They want to know your opinion on that. Any surgical procedure needs to be done on the baby or the mother or both?
Sorry, sir, I am not sure about that.
Okay. And they want to know, like, what would be the usual course of events, prognosis is, what would you say?
The problem or the complication of PUG obstruction would be, most of the time it is diagnosed incidental. So I would reassure the patient or the parents, most of the time it is incidental, asymptomatic. Other than that, they can get loin pain or incidental mass, or there's a chance of recurrent urinary tract infection. Nevertheless, all depend on the severity of the obstruction.
Okay. Yeah. All right. So now, and then you get a call from your friend obstetrician also. So sometimes they also want to clear things up. So they want to know whether you would like to do anything to optimize whether there is anything, anything fancy that come up recently that will change the course of events, any medication or anything to optimize fetal renal outcome?
Sorry, sir, I could not recall anything.
Okay. So, and also, say if this patient has oligohydramnions, would you give anything to improve the overall outcome of the baby?
I think if it is an oligohydramnion, there is a chance of pulmonary hypoplasia, in which case surfactant or would be better.
That would be more postnatal, isn't it? So anything that's given can be given to the mother.
Steroids.
Yes. Yeah. Steroids will be indicated depending on the obstetrician's view as well. Yeah, so so that's one thing. Yes. So fetal intervention we talked about, and he wants to know whether you would like to, go on for an early labor, or you can, what is your advice regarding timing of delivery to the obstetrician?
It's again depend on the severity of, as you said, oligohydramnions. If things are fine, fetal growth is okay with the POA. No need to rush for the delivery. It can be go ahead with normal timing.
That's right. Oligohydramnios is more hypothetical, and I just put it forward because this child has only unilateral hydronephrosis. So oligohydramnios is very unlikely in this baby due to renal urine output, the low urine output. So yeah, so in this patient, yes, so there is no need for change in the delivery time. Yes. Okay, so 8 weeks later, this is 8 weeks later, you have forgotten all about that patient, and suddenly they pop up in your clinic with a tiny baby, and so what would you do then? Now the 1-day-old baby coming with the parents, they are very anxious. What would you advise?
So is it 1-day-old baby, sir? Or?
Yeah, soon after delivery, 1-2 days maybe. Yeah.
Okay, sir. Because soon after the delivery, baby would be dry and the renal tract is more or less developed. So
Yep.
that doing a scan at that time would be not beneficial because the hydronephrosis, the diuresis would be not much there, and the pelvic
So when is the
dilatation would.
optimum? Yeah.
So I would wait for a couple of weeks, 1 to 2 weeks, for the renal tract to develop, and then I would repeat a scan to see the actually from kidney to bottom. I would see the severity of the PUG obstruction, AP diameter, cortical thinning, and any cyst, any dilatation of the ureter, which will change the diagnosis, and then the blood and the posterior urethra. Sir.
Yeah, but these parents are, super anxious. They are. It is impossible to convince them to stay for 2 weeks. And it's the earliest that you would do a scan reasonably. I mean, any useful scan. If 2 weeks is a little too long. The waiting time for the ultrasound, you said, is about 2 weeks.
Yes, 1 to 2 weeks. Yes, 1 to 2 weeks.
24 hours, it's pretty much useless, to say, sometimes you still see dilatation, but it might not, you might miss a few because of the physiological kind of dehydration or oliguria in the initial hours, especially if it's a stressful delivery. Yeah. So maybe 48 hours, would you say, if the parents suggest, can we at least do one in 48 hours? Is that a reasonable thing to do, ultrasound by about 48 hours?
But it won't exclude absence of obstruction. But if there is an obstruction, if there's a dilatation, yes, we can diagnose. But I would make sure that we cannot exclude it.
Yes, you can't reassure the parents and go, but majority of the significant PUG obstructions will be, visible in 48 hours. Maybe few you might lose, insignificant ones, particularly ones that are going to resolve anyway. Okay, so general tendency is to do the scan at about 48 hours. 48 to 72 hours, yes. Okay. And so ultrasound, what are you specifically looking at? You mentioned already. So can you list them down, the most important things that you would want the radiologist to comment on?
Dilatation of the pelvis with specific transes, AP diameter of the pelvis, and then cortical thickness of the kidney, and then whether there's presence of or absence of dilatation of the ureter.
Yeah.
And then is there any other obvious abnormalities in the renal tract, like coexistence of any other abnormalities, like thickened blood or reflux on the other side, causing hydrureter, and any dilatation of the posterior urethra?
Yes. Yeah. So blood evolution, yeah, you can come down from the ipsilateral kidney, then you look at the other kidney, then the bladder, ureter, bladder, and the urethra. Yes. Yeah. So they shows isolated unilateral hydronephrosis, and there is no bladder wall thickness, ureter not visible on both sides. The opposite kidney is normal ultrasonically. What would you do then?
Again, sir, would I know the AP diameter of the pelvis?
AP diameter is 2.5 centimeters.
Okay, so this a bit of the AP diameter is a bit of discussion point, because natural history of PUG obstruction. I said that the indication for intervention differs with the AP diameter, because some say it should be intervened if it is more than 50, and it may not be intervened less than 20, because percentage of need.
Time is up. So now it's almost 12 minutes. So you can give the feedback, sir.
Yes.
And actually, it's a very good scenario, and sir have asked the same question that will ask in the real exam. And yes, sir. So your feedback to Taha, sir.
Yes. So you want me to give a mark straight away, or?
Yes, sir. Yeah. Yeah. Out of 8.
Out of 8, I think I would give a 6+, or maybe close to 7.
Okay, sir. And any feedback to Taha, sir?
Yes. So I think he was quite thorough with the subject. Yeah. So maybe we would have liked to have a few more minutes to complete the scenario a little bit further, you know.
Yes, sir.
But I think he covered most of the things. So, you know, the differential diagnosis of antenatal hydronephrosis, it's not only, you know, you just see the hydronephrosis, but you have a differential diagnosis there. So it's not PUJ obstruction only. And so all the other scenarios like PU valves or VU reflux or even MCDK can come like a PU, you know, like a hydronephrosis only, because antenatal height is not as good as a postnatal scan, or not as complete as a postnatal scan. So so he was discussing all that, and then how to, you know, calm down the parents, and then go on from there, I think. Yes. So whatever, you know.
So, commonest cause of antenatal hydronephrosis is a physiological, is it, sir?
Physiological is about 60%. Yeah, about 60%. Yeah, I think we have a few slides. If you want to, we can go through that. I have prepared a few slides.
But sir, we will do that, sir, after the session. But
yeah,
common thing is the physiological.
Yes.
And the second common organic cause is the PUJ obstruction.
PUJ, yes. PUJ obstruction.
Okay, sir. Yeah.
Then the PUR, then the, you know, much later for about 1 to 5% would be PU valves, and then some MCDKs also can be mistaken as hydronephrosis, like that. Yeah.
Okay. Suppose if you plan for a Dtpa, sir, so when we can do as early as possible, 3 months or 1.5 months?
Yeah, our radiologists would do it 6 to 8 weeks down the line, mainly because everybody is so anxious to know, particularly if the epidiameter is anything over 2.5 centimeters, the postnatal epidiameter, they would do a early, very tempered Dtpa, or now we have MAG3 as well.
Yes, sir.
So that's a little better.
Yeah. So I think the our colleagues have to know the difference between MAG3 and the Dtpa. So what's the advantage of MAG3 over the Dtpa?
That was that would have been my next question. Actually, I was trying to get at the next one. And then go on to the different mode, you know, different types of isotope ranograms and advantages, disadvantages, like that.
Okay, sir. Anyway, it was a good discussion. So antenatal hydronephrosis is a very commonly asked scenario, and it was nicely prepared scenario. So thank you very much. So we are moving to the next scenario. The examiner will be Dr. Kanjana, and the candidate will be, there are a few candidates not here because of the power cut and things. So we'll start with Dr. Nalin. Okay, Nishantan is here. So Nishantan, shall we do the next one?
Yes.
Yeah, okay. So Dr. Nishantan will be the candidate, and Kanjana sir is ready with his scenario. Time starts.
Okay.
Start.
I'll briefly show my question to you, Nishantan, and after that we will continue our discussion with the scenario, right?
Okay.
So this is where is okay. This is my question, right? Can you see me?
Yes, sir. Good evening, sir.
Right. Can you see my question?
Not yet, sir.
Sorry?
I couldn't see your question, sir, yet.
Okay, I'll tell it to you, right?
Okay,
so,
sir.
Give me 1 second. Sorry about this, right? Okay. No, give me 1 second. It's slow. Right. Okay. So my question is again something to do with hydronephrosis, right? In your clinic, you see a 3-month-old infant. There was a severe unilateral hydronephrosis detected antenatally.
Okay,
rest of the renal tract has appeared normal on all the antenatal and postnatal scans.
Okay.
What is the most likely or scan? So how are we going to proceed with from here?
So I want to clarify the things, sir.
Yeah.
Antenatal scan, there was a severe hydronephrosis. What about the postnatal scan?
So this is the ultrasound scan of when the child is 3 months old,
Okay,
right?
sir.
So and it has been the rest of the renal tract can appear normal. All the antenatal and postnatal scans, right?
Okay, sir. So anyway, I will go through the basic history and examination of the patient and antenatal history and familial history. And according to the scan, it's a 3-month-old baby, only the hydronephrosis. I want to get to know the further details about the hydronephrosis, about the AP diameter, and also the about the other side kidney and the bladder. Those features I want to know. And if the
So they all are normal.
okay, so in that case, I want to know about the renal function, and I will discuss with the patient that most probably it could be the pelvic ureteric junction obstruction, isolated pelvic ureteric junction obstruction. So to further clarify the diagnosis, I will do further investigation like isotope scanning, specific.
So in this ultrasound examination,
Yes, sir.
hello, yeah, in this
Yeah, I
ultrasound
can.
examination, what are the things that you like to concern most?
I want to know about the AP diameter at the transverse.
So what are the things that will tell to you the AP diameter of the scan?
AP diameter scan is if it is more than 2.5 centimeter, then it's significant, and if it is more than 5 centimeter, then of course we have to go for a surgery, and so and also about the cortical thickness, thinning of the cortex, and also the involvement of the ureter, dilatation of the ureter, about the other side kidney and the bladder, and whether the patient is having absence bladder or the presence, we can see the bladder, and possible urethral dilatation, posterior urethral dilatation. I want to see those features.
So only the hygiene process we could see. Yeah.
Okay, sir. No,
and then
cortical thinning, yes.
Yeah. So can you grade hygiene process and hygiene depending on the AP diameter? Can you grade the hygiene process?
I'm not pretty sure, so I couldn't recall that. But according to the Dillon study, natural history study, he has given according to the size of the AP diameter, the management will differ. So if it is more than 5, we can go for it. Less than 10 millimeters, then we can ignore it. In between, depend on the patient condition, we have to manage.
All right. Okay. So what are the tests that you would like to do to confirm this diagnosis?
So 3 months old the baby. So I want to assess the function, confirm the diagnosis of PG obstruction with the isotope scanning, preferably mercapto triglycerin scanning. So.
So what are the details you can gather from that scan?
From the scan, I want to know about the both split function of the kidneys, and also about to know about the curves, how the renal concentration, the isotope concentration, and excretion happens. The split function, and are there any curve is suggestive of obstruction or not? I want to see, sir. And if it is less than 40% of split function, and then I have to consider it as a significant one to go for a management, so surgical management.
If it is what percentage?
If it is less than 40, split function is less than 40%.
Sorry, I'm hearing problem with my. Tell me this.
Split function is less than 40%, then we have to go for a management. Yes.
Okay, so you can see the split function, and then how are you going to find out whether this has got a obstruction or not?
One thing is the function. Split function is low, then we have to. There is some abnormalities there, and we can see the graph about the right side and left side excretion.
So what is so special about this graph?
We call it as orally patterns. So if there is a initial part in the initial time, then there will be a uptake of tracer elements, and there will be a gradual excretion of the isotope. But if there is a gradual, there's no excretion persistently, it's there, then we have to consider there is a possible PG obstruction. So we have to compare the both graph, right and left graph.
Okay, what do you mean by diuretic renogram?
Diuretic renogram, to make clear, to have a clear idea, we can give furosemide injection. So if there is any obstruction, then it will show more clearly with a diuretic urogram. So most probably it is given in 20 minutes after giving the injection, but in pediatric practice, they used to give it in the same time of isotope scan injection.
All right. So when you are going to explain all this into the patient's parents, isn't it?
Yes, sir.
So if they ask what are the risks carrying in this examination, what are you going to tell?
I will explain them.
They are worried about the radiation exposure and all.
Yeah, I will explain them that it will be the child has to take onto the radiology department, and also they will put a intravenous access, and the child should be hydrated well before the procedure. And the radiation, of course, it is theoretically it is less than 0.5 sievert. So it is less than the radiation of a plain abdominal X-ray. So there is a radiation risk, but it is less than the plain X-ray.
So, right. Okay, what are the disadvantages, or what are the things that we can't gather from this examination?
If the renal function is less, then the usage of the renogram will be a problem, so we can interpret sometime. And if the patient is having vesicoureteric reflux, so in that case also it will be difficult to interpret. So we have to, interpretation should be proper. And since the baby, cooperation of the baby might be difficult in 3 months old child, so that might be the problem. And I'm not sure about other things, sir.
Okay. Can we get anatomical details with this scan?
It's basically a functional scan, but we can get some anatomical information by the mostly the function, bladder, excretion, and those things. If you want to have anatomical details, then it will be the compared to the isotope scanning, and DMS scan will be better, where it stay with the kidney cortex. So.
Yeah, but if you want to plan a procedure or something, then how are you going to get the anatomical details?
Already we have the ultrasound scan, and the functional scan is also there. So in that scan case, we can go for a CTI view or to diagnose the anatomy and also the surrounding structures anatomy to plan the management.
Okay, so we can do a CT IVU and get the anatomical details, isn't it?
Yes.
Right. Okay. So with all these things, you are going to diagnose a PUJ obstruction in this patient. So what would you think the etiological factors behind a PUJ obstruction?
There are possible explanations are there. In PG obstruction, there is a functional and as well as the anatomical part is there. A peristaltic segment and hypoplastic segment might be there at the PGA junction. And also there could be in elderly patients, sorry, not the elderly, elderly children, there might be possible crossing anterior segmental vessels might be there, the lower pole. So that might cause the obstruction. So.
All right, okay. All right, so So what are the options you can give to this patient, 3 months old? How are you going to proceed with the management?
So management, of course, you have mentioned that severe hydronephrosis, most probably it should be more than 5 centimeter. So we have to offer surgery for him. And so I want to have the basic renal functions and those with the patient informed written consent and the parent involvement. And we have to go for a pyeloplasty in this child. So if there's no significant deterioration, we can even after 1 year, where the surgical and anesthetic complications will be less compared to the younger child. So we can plan the PGA repair, pyeloplasty.
All right. So
And
what are the
SMH,
PGU repairs you know?
there are several techniques. What nowadays the commonly practiced is Anderson-Hayne dismembered pyeloplasty and VY plasty. According, if the vessels are not crossing, then we can do the VY plasty. So according to the anatomy, we can plan.
Thank you. Time is up. Time is up.
Okay.
Sorry, sir.
Thanks,
Sir, you can give the feedback to Dr. Nishandan, sir.
I think he's fairly all right with the PG obstruction, isn't he? So he has got a good idea, but I didn't go into the questions like when to do the surgical procedure and all, but he's aware of the most of the thing. So I think it should be fair enough, isn't it?
Okay, sir. So you will give 6 or 7?
Yeah, most probably 6 or something.
Okay, sir. And sir, will you recommend doing a CT urogram in a toddlers or infants, or you'll proceed with the scan and the Dtpa, or will you do a CT urogram in a PUG obstruction?
So from me, I think that will be best answered by Dr. Sanjay. Going to say everything.
Sanjay, sir?
Because
Yeah, so our radiologists would be extremely anxious. So we haven't done any IVU, CT, urograms for a long time now. So we would rely on the symptomatology of the patient, whether they are symptomatic or asymptomatic, then the ultrasound, the epidiameters, cortical thickness, and basically that, and then the progression as well, and of course the diuretic renogram a lot, and then there we would look at the individual split functions and the curve, and then those spot films as well. So we combine all three. So symptomatic ones we are very keen to on surgical. Say if there is a palpable tense lump on the line, or pain which is due to the pain, abdominal pain in lots of kids, if they are having intestinal colic, constipation, those things can cause there are lots of other causes that will cause pain, but pain that is classical enough for you to think, okay, this is renal pain or like a diabetes crisis or thing like that, then that will be in favor of surgery. Then the ultrasound AP diameters, we would probably, depending on the child, sometimes in a 3-month-old, diameter of 3.5 would be equivalent to a 5 centimeter in a 14-year-old. So individual numbers are difficult, but the progression would be a little bit more useful also. So, and then of course the renogram as well. So those are the three that we would.
Yeah. And you will do usually F+20 or F+0, so in children's, the diuretic renogram. So
20,
they give
yeah,
the
20 at 20 minutes. Yeah, yes, at the peak of thing. So 20 minutes, but some of my colleagues were keen to give it. You mean the diuretic, no?
Yeah.
Timing of the diuretic?
Yeah.
Timing of the diuretic, they like to give it at the peak, but no, I think we had a senior urologist, the radiologist, who would give it almost at the time of the contrast appearing, I think isotope appearing on the first images as well. So, but then the classical thing is to give it at 20 minutes, I think. Huh?
Yeah. So answer sometimes
most of the books mention it is 20 minutes to do the diuretic, isn't it? So,
yeah. But sir, you
then,
get
then only they.
Yeah, equivocal graphs, you won't get much when you give in F+0. because if you give early diuretics, so diuretic action will come after 10 minutes. So the equivocal grafts patterns will be less when you give in F+0. And giving at the same time both is easy in children. I don't know.
That may be. Yeah, that's another reason probably. Yes, yes. Yeah. Pediatric, I think there was a radiologist from Great Ormond Street who visited LRH some time back, and he suggested that we give it early. And so I think our people followed that protocol for a while, and now I think it's a bit variable among the consultants also. So
yeah,
but I think
suppose, sir, if you decide for a follow-up of PUG obstruction, how frequently you will do ultrasound scan and DTPA?
Ultrasound we would do more often, so maybe every 6 months, and a DTPA probably annually, depending again if there is if you feel that this can deteriorate, you know, I mean, so if the epidiameter is either static or rising, then you would do a DTPA earlier than, or MAG3 earlier than you would otherwise. But so first year, definitely every, you know, the 3 monthly ultrasounds and 6 monthly DTPA or isotope scans, and then probably second year onwards annual DTPAs. But the ultrasound, you can be a bit more liberal with it. So there is no strict protocol that we follow, but then all depends on your, if you, the main worry is that the next ultrasound suddenly will be 5 centimeters and the split function 30, you know, coming down from 50. So that would be the worry. So, but then if your, you know, epidiameter is 1.5 centimeters and then it's been static for 2 or 3 scans, then your next one will be a little bit further down the line. So probably first year you are a little more worried. You don't know which way it's going. So you will do ultrasound every 4 months. Our radiologists wouldn't be too unhappy to do ultrasound every 4 months or 3 to 4 months in the first year. And the isotope renogram certainly you would do in 6 months. So you normally we do one around 6 to 8 weeks, and then the second one maybe 6 months if there is a big worry, and then 1 year, and then from there onwards there is no strict pattern, but probably in the second year you would do one at the end of second year.
Suppose, sir, if it is a non-functional kidney with the thinned out cortex, with asymptomatic and renal function is normal, will you intervene, sir?
It all depends on the, if the child is having hypertension, or if the child has you know, palpable kidney on the loin but non-functional. Normally or most of us at LRH at least would not you know, they would first put a nephrostomy and then you would repeat that, because if the original DTPA might say 2% or 5% or 10%, but then suddenly we have had the occasions where once you drain it or once you decompress it and the follow-up scan suddenly will be 30%. So certainly we wouldn't take the split function, low split function on a isotope scan just to do a nephrectomy or some drastic procedure, certainly not. And majority would don't want to go and do a pyeloplasty also on such a low one. So you would decompress it and then reassess the split function. But there is a school of thought that when you put these, it's a bit messy. The small babies having nephrostomies around for a while, they get infected, they get dislodged, and a whole lot of problems. So some would argue that it's, and also the surgery becomes a little bit messy as well. You know, it's the tissue planes, the pelvis is a little inflamed, and erythematous, contact bleeding, all that. So, and the ureter tiny. So, but you know, so then there are a few who would try to buy some time and then do it around maybe 6 months, a pyeloplasty also. But the majority agree that you decompress it and then go for the, you know, repeat scan and then carry on.
Thank you, sir.
But a nephrectomy is almost out.
I got to ask one question as well. Yeah. So what is your experience about MRU? Are you doing it in LRH or?
Magnetic urograms, you know, I think our software is not very good. I mean, we don't get that great images that we see on books. with, particularly in small babies, we don't get that nice definitions, you wouldn't get much additional information from our magnetic urograms. So that's the main reason. But I've heard that, sometimes you get more anatomic detail, particularly if you have lower polar vessel crossing it, and that kind of detail should be there, but we rarely do it prior to a pyeloplasty. Yes. Maybe on a particular instance where the radiologist also is of the opinion that it might give you additional information, but I have never requested one, but I have seen a few magnetic urograms, but they rarely give additional information sufficient enough to change our practice. But it's definitely on print that it is useful. Yes.
So once you've done the surgery, pyeloplasty, sir, but what is a follow-up plan? Scan and Dtpa will you do regularly or what?
Certainly not Dtpa, but ultrasound definitely, yes. Ultrasound we would do regularly, not immediately, but some people would do it at 3 months, others would do it at 6 months, but I would usually go ahead with a 3-month ultrasound. And then the need for a Dtpa usually depends on the ultrasound findings, but at 1 year, normally we would do a Dtpa for record keeping and to see how your pyeloplasty has worked. But post of Dtpas can be quite tricky if the radiologist is not on the same this thing. They might suddenly say they might expect it to be like curving like the complete perfect. It will never be the case. Yes. So yeah, the Dtpa has to be interpreted by a good radiologist. Yes.
Are you using a stents after the PUG repair? Or
yes, all of us use a French 2 or 3 double chest stent after the thing, and we would normally remove it early. I mean, some people, it differs among surgeons at all, but I usually would remove it pretty early. Probably 4 weeks is our standard time. But I've seen GOS and Birmingham, they would remove it at 2 weeks also. I don't know. But they think that it's of no use beyond that. But it's mainly initial, post-op edema, the PUJ that they want to tie over. But 4 weeks is a reasonable time to leave it. What's your experience? I think the urologists leave it a little longer, or you?
Yeah, because for adult population, you would leave it for at least 6 weeks, isn't it? So that is what I practice.
Yeah, I don't think there is a problem that way, but
well, they were saying that they are anastomosis without the strength in pediatric population. That's why I asked that question.
Quite a few. Yes, quite a few would do that. Some people would actually put a from a nephrostomy, like a little coil in the, like a double J kind of coil in the pelvis, and then the distal tip in the ureter, and then he pulls it out. I can remember Indian, his special, he has his own tube, I think, self-retaining coil-like thing in the pelvis, comes out through like a nephrostomy tube, and the distal end in the ureter, not the bladder. So it can be pulled out without a cystoscopy. Yes. Usually in about 10 days, I think he pulls it out. Yes. So there are different. Yes.
Thank you, sir. Thank you. So we move to the third scenario. The examiner will be Sanjay sir, and the candidate will be Dr. Munipriya.
Okay.
Yeah. So time starts. So over to you, sir, and Dr. Munipriya.
Good evening, sir.
Yeah. Good afternoon. Good evening, Munipriya. So nice to see you. Okay. Let's see. Just going down. Yeah, so this is a 3-year-old Madhusha who is brought to your clinic by mother she has felt a lump. So she was giving her wash in the evening one day and suddenly got startled by finding a hard mass on his left loin. Okay, so what would you like to, so this is the baby, but what do you want to do now? So you can question the mother, examine.
As this child is 3 years old, I want to go through the history and examination, thorough history from the parents, and that is starting from the antenatal history as well as the neonatal history.
Okay.
And
what would you want to know?
Antenatal, any anomaly scans, and whether they have detect any abnormality in the kidney, ureter, bladder, especially the kidney.
Okay.
Any dilatation of the renal system or any masses related to the kidney.
Okay,
And
so they haven't picked, yeah, so in this baby, the antenatal scan didn't show a hydronephrosis. The baby was basically normal.
Okay, sir. Then immediately the neonatal examination, whether the neonatologist or the pediatrician has picked any abnormalities in the examination during the neonatal examination, early neonatal examination.
Anything in particular?
Again, the one thing is the abdominal masses. The second one is outflow. Also, I want to see that the external genitalia.
Okay.
And,
okay. So no undescended testes, no hyperspadias. Abdomen had been normal.
Okay, sir. And then during the initial time period, whether the child is having any illnesses, which is the recurrent hospital, the need recurrent medical advices or medical seats, and
no, had been pretty much a normal child, yes. Hardly had a flu or cold, and had been only to the postnatal clinics, the baby clinics, but nothing more other than that, yes.
Okay. So other thing is important thing is the any episodes of hematuria, which may.
Yes, this child has had a episode of dark urine, which the mother didn't really take notice of it. But whether it's frank blood, she wasn't sure. But she mentions that the urine color was on, a couple of weeks back had been a bit dark and suspicious, but not very bright red, yes.
Okay, sir. So because of that history is very important. So I highly suspicious of any renal masses. So in this child, particularly nephroblastoma, like the tumors, renal tumors may be present as this picture is giving me. So I want to exclude that. For that, I would examine.
The mother also has observed that this child was having a fight with his eldest brother a week ago, and then the mother thinks that he was given a blow on the tummy by the elder brother.
Okay, sir. That trauma history also very important. I have missed that part actually. So then once I examine then important thing is the basic investigation and the specific investigation to pick up what is the mass. So in the so my main differential diagnosis is the renal tumor, nephroblastoma, and other thing is Wilms tumor, and other possibilities are the lymphomas also can be present as this type of picture, and the sarcoma, the retroperitoneal sarcomas.
Okay.
Any other sarcomas?
Any other sarcomas?
Rhabdomyosarcoma.
Of the? Sarcomas of the kidneys. Have you heard of a sarcoma of the kidney?
Leiomyosarcoma.
Clear cell sarcoma. So if this child was 1 year old or 6 month old, but what tumors will click your mind? If it is now you were thinking of, say, if this is a 3-year-old, the Wilms tumor or the nephroblastoma is high on the list. We're just talking of tumors. So if it is a 6-month-old, what tumors would you be more concerned about, would come to your mind? your sarcoma, the clear cell sarcoma. Yes, so the clear cell sarcoma, the classic age is 1 to 2 years, but
sir.
it can be from about 6 months onward until about 10 years. But the peak incidence is around the first year. And the mesoblastic nephroma, so that's also a form of tumor, pretty benign one, only need a nephrectomy. And so that's around 6 months
early.
to 1 year. Yes, yes, okay. And rhabdoid tumor, so that's also like a rhabdoid tumor. It's not the rhabdomyosarcoma, but the rhabdoid tumor is a very malignant tumor, again in young children. Okay, so massive, yeah. So this is basically the one. And how would you differentiate now? Say, so kidney problems, hydronephrosis, renal tumors, and maybe bleeding into a tumor or bleeding into a hydronephrotic kidney would be possible. And then what are the other non-renal which can come in that region? In children, the neuroblastoma, particularly the adrenal neuroblastoma, would be pretty much in the same spot. And even a massive splenomegaly, you might have to, by just watching it, you have to, obviously it's easy to exclude. And then you can, so how would you differentiate a neuroblastoma from a nephroblastoma?
In history wise, the important thing is the loin mass and the hematuria. So more prone to get hematuria in nephroblastoma rather than the neuroblastoma.
Yeah.
And in neuroblastoma, the paraneoplastic syndrome.
That's right. Yes. Yeah. So fever, child may be unwell. Yes. So they are more likely to have those symptoms additional. And also the tumor is more likely to cross the midline in the neuroblastoma than in the nephroblastoma. If it is a solitary adrenal neuroblastoma, then it might not, but yes. So, so the duplication cysts of the descending colon or even small bowel, that kind of thing, you have to. And so what is the investigation of choice now? Straight away, what are you going to do for this child?
So the first, I want to do the blood investigation and the non-invasive, the imaging techniques, especially the ultrasound scan abdomen, and in blood investigation, basic blood investigation, including the full blood count, CRP, and other renal function, those things. And in ultrasound scan, I would look.
So this is your ultrasound scan. Yeah. So shall I?
So ultrasound scan may show the enlarged the renal mass with maybe associated the hydronephrosis or hydrochalicosis, which is compressing the excretory system, and it's usually the well demarcated mass, and sometimes there will be a hyperechoic area showing the bleeding into the mass.
Okay, so what do you think is this ultrasound showing?
So it's it shows the I think kidney with well circumference lesion in one area, with the other calyceal dilatation. I can see
mid and lower pole nephroblastoma, I think. Yeah. So what would you do next now? Anything else that you can ask your radiologist? Anything else you would have liked your radiologist to comment on in this ultrasound? So they would have seen a lower pole or mid lower pole nephroblastoma. And no capsular invasion. I mean, you look confined to the kidney.
And other contralateral kidney, the appearance of the contralateral kidney.
Yes, contralateral kidney, but there's any bilateral synchronous lesion. Anything else? The ultrasonographer will help you, which is of major, which will have major bearing on your subsequent surgery, is the the venous system, no? The renal veins, the IVC, they might be able to comment on those things. And also, so you would ask for a
CT
yes,
scan,
yeah,
contrast
CCT, yeah.
and CT with the preterite phase of urine.
Okay. Yeah. And again, you would be looking at the veins, whether there is thrombus in the vein, IVC, and so, and also, of course, the staging of the tumor. And anything else that you would want, especially if there is a suspicion of thrombus, IVC thrombus, what would you want to do?
Especially I want to look for especially I want to ask for the echocardiogram.
Okay, yeah.
See the
echocardiogram to look for IVC, atrial thrombus, yeah.
Atrial thrombus.
Okay.
And in CT, I would look for the renal vein and the IVC thrombus extension.
Yeah, so this patient has a IVC thrombus extending into the atrium. And what would you do next?
I would discuss with the MD, especially the multidisciplinary team meeting.
Who are the members?
The cardiothoracic surgeon and cardiologist and nephrologist and radiologist, pathologist, and the pediatrician.
And the pediatric oncologist, yeah?
Yeah.
Pediatric oncologist would be also important. Why?
Because the neoadjuvant.
Yes, yeah. Why is it especially important in this patient, the neoadjuvant chemotherapy?
Because the small child, once the neoadjuvant is given, the tumor shrinkage will help to surgeons to get the adequate exposure and the space.
That's right. Tumor rupture would be less, and also particularly in this patient, what is the other advantage?
Because of the IVC and the thrombus extension from micrometastasis and
also the tumor thrombus. The tumor thrombus will be less friable. So when you remove it, otherwise it can go into piecemeal, but once you give chemo, it becomes a little bit more less friable and it will come off in a single piece. So you can.
Thank you, sir. Time is up. So you can give the feedback to Dr. Munipriya now, sir.
Okay. So as usual, we were a little short of time. So we would have liked to, go on a little bit further for us to give a proper mark, but I think we probably should time it. I should have timed it a bit better. So go into a little bit more depth of the case. We were almost touching the surface. So I think, but so it's all my fault. So we could have gone a bit further too. So I think you answered most of my questions. So I would definitely give you a 6. I'm sure we would have given a better mark had we gone a little bit more deeper, but certainly you answered all the things that, most of it that we discussed so far. So the timing is the issue, I think. No? So we probably should get into a little bit quickly.
He answered in a slower phase. I think I have to increase the phase of delivery of the answers. You have given more prompting. So if we can, answer in the first go, then we can save some time. And sir, will you do a biopsy, sir, before the surgery?
Yes, we at LRH, and then we follow the COP protocol. So we are more continental, European oriented. Certainly now the NWT as the National Women's Tumor Study Group, the American thing is particularly for the stage 1, 2, 3, those diagnosed with nephroblastomas, if they are quite convincingly nephroblastoma on imaging, then they would not biopsy. The initial histology is obtained at nephrectomy and then subsequent chemotherapy, but we follow the COP, so we do biopsy. But I heard some European centers also now going away from true cut biopsy because it upstaged the tumor to the next stage on their protocol, the chemotherapy protocol. So because of that, they avoid. But we at LRH, we do a biopsy, a true cut biopsy, confirm is because our pediatric the oncologists still like to give upfront or neoadjuvant chemotherapy with usually vincristine, actinomycin, vincristine, I think.
Yeah, your patient also, there also 2 plasters, must be biopsy plasters, sir.
Yes, yes, a little biopsy.
Yeah, and suppose, sir, if there is a lung mets, is the management is changed or?
I think if there are metastases, they would give chemo, I think, definitely upfront, I think. And majority, I don't think they do resections, but if there are suspicious lesions, particularly a chest X-ray, not CT, sometimes you're not, probably some of the lesions may not be Wilms tumor alone, like, these tuberculomas. Lots of other lesions also can be mistakenly identified as TB, like secondary. So then they might biopsy the lung lesion. But if there is a new lesion appearing, I think there is a particular protocol for that. I'm not, very
Okay,
convinced about what it is, but.
So as you said, sir, this is a classical
our
age.
situation now, all of our patients get neoadjuvant chemo, and then we are going for surgery, and then they fill it up. They will give us a narrow window to do the nephrectomy and send them back and to complete the chemotherapy in our situation. So whether with lung mets or not, it's more or less the same. But I think in American setting, the grade 4, the mets or bilateral tumors have upfront chemotherapy and then surgery. But 1, 2, 3, I think they do initial nephrectomy and then chemo.
And you were asking the differential diagnosis, sir. I think we have to press more on gross hydronephrosis as well, isn't it, sir? That is sometimes can present like
massive. Yes, but I think India, that antenatal scan and it's unlikely that you will have a massive one which is not there. Usually it's a missed antenatal, if majority of them don't have anomaly scan. So that situation, yes, because of that, I didn't really emphasize on that because it was ruled out. But yeah, that definitely is on the cards. Yeah.
And you ask about examination. Do you expect
that
hemi-hypertrophy?
Yes,
and some aniridia and things.
Yes, Vega, yeah, Wilms tumor, aniridia, mental retardation. So that's Vega syndrome. Then Dennis-Drash syndrome, and then the Beckwith-Wiedemann, and lots of other syndromes also, which are supposed to be.
If you mention 1 or 2, that is, I think, in examination will be very nice, right? Thank you, sir, and thank you, Dr. Munipriya. We are moving to the 4th scenario. The 4th scenario, the candidate will be Dr. Hilary Fernando. Again, the examiner will be Dr. Kanjana, and Dr. Kanjana and Dr. Hilary Fernando. Dr. Hilary, are you here?
Yeah, I'm here.
Okay, right. Over to you. Yeah, time starts.
Good evening,
sir. Hello, everyone. Yeah, good evening. I'm going to give you a scenario, right? You see a 15-month-old boy in a clinic. He has normal scrotal testes on one side. Despite your very best effort in this cooperative infant, you are unable to palpate the other testes, right? So this is your patient. So how are you going to proceed with this?
I missed the side of the palpable testes.
It is only one. They mentioned one side, so we'll take it as left side.
Yeah. Now, how would I approach this patient? So most probably this patient may be having cryptorchidism. So then I will take a focused history and examination with the guardians and parents and present, and I will see whether there was any history, whether the absent testicle was there before this particular instance. And
what do you mean by that?
Now, 15-month-old boy And if the mother has detected the
15 months old, right?
Yeah, 15 months.
Yeah.
Yeah. So if the mother has detected both testes before, and whether it has disappeared now, and whether there was any history of painful swellings and or any hospitalizations with the swellings and all. And in
There's
the
nothing like that.
Yeah, in the examination, I'll palpate the normal side, see whether it's in the normal size and orientation, and the absent side, whether the scrotal sac is normal or hypoplastic, whether I can see any visible lumps in the line of the descent, or I can palpate the testes in the inguinal region, root of the penis, superficial inguinal pouch region, or any other ectopic places. Whether if palpable, which is whether the testicle can be brought down to the fundus of the scrotal sac, and whether it stays in the fundus of the scrotal sac, or whether it will ascend back, whether there is tension or whether there is tenderness in doing so. The external genitalia, whether there are any significant anomalies, like hypospadiasis or any other issues like that. Now it's a 15-month-old boy, and if it is not palpable, which usually most of the testes are palpable, about 80% of the testes are palpable in cryptorchidism, but if it is not palpable, then it's possible that it is in an intra-abdominal position, or it's probably not palpable with in a normal child without anesthesia.
Okay, so you are planning to investigate this child, is it?
Yeah.
Okay.
So I will request an ultrasound scan abdomen.
Is it going to help?
See whether in the ultrasonography, whether the sonography can find the. Sorry, I missed that.
Is it
Hello?
going to helpful to you doing ultrasound examination in this child?
Might find the testes, but it's most commonly it is not going to be very helpful because the sensitivity is not great. So, so because of that, now since it's a 15-month-old boy, we need to, if it is not in the scrotal sac, we need to act quickly and see whether the testes can still be salvageable in terms of. Yeah. Why
do you want to act quickly?
Because now the spermatogenesis of the neonatal testes from the neonatal like the gonocytes to the formation of adult dark spermatogonia and then the adult light spermatogonia. This thing happens in the 3 to 12-month period. Now that it has sort of elapsed, and the evidence say if we manage to salvage the testes before 2 years, the paternity rates can still be improved if we do the Okidectomy before 2 years. But beyond 2 years, the paternity rate preservation is not. But in this child, there is one testicle in the other side, so that will be a consolation factor in terms of fertility.
Okay. So so you couldn't find the testes in his scrotum, in superficial ring or the deep inguinal ring. So what is the next step you are going to take?
So if I can't locate, then the next step would be to do a laparoscopic assessment to see whether I can find the testes in the intra-abdominal position. I'll take the consented prepared child on supine position, and I'll have a look inside the peritoneal cavity, whether the vas is entering the deep inguinal ring, whether the arteries are entering the deep inguinal ring. So out of the 20% of the patients who will have non-palpable testes, about 40% will have intra-abdominal testes, and about another 30% I might find about both the vas and the testicular vessels are entering the deep inguinal ring, and about 20% or so might find a remnant or testicular nubine. And sometimes I might find the vas and the vessels ending without nubine or a testicular tissue. So in that situation, then I can rule out that the testicle is not there. If I find a nubine or a remnant testicular tissue, then I'll probably remove it, because then the risk of later subsequent malignancies also high in those tissue.
Okay. So if you happen to find the intra-abdominal testes, what are you going to do with your laparoscopic examination?
Yeah, so then if I find the intra-abdominal testicle, things I'd look for whether the vas and the vessels can be mobilized, whether it is situated close to the deep inguinal ring, and whether they are close to the deep inguinal ring, and whether I can safely take them down without significant tension into the deep inguinal ring. Then if so, then adequate length, then there are two, either the one stage Fowler Stevens or two stage procedures are there. If the length is not adequate, then I would remove, I would clip the testicular vessels and leave the testes on the supply of the artery of the vas. So we'll develop collaterals and survive on the artery of the vas. And then
so I didn't hear the last part.
Sorry, sir. So it depends whether I can do single stage or two stage Fowler Stevens procedure. And if the vas and the vessels are good length, then maybe I can do single stage. If not, I will clip the testicular artery and the vein and leave the testicle on. Can you hear me, sir?
Yeah, I can.
Yeah,
I can.
And I will leave the testicle on the artery of the vas, so it will survive on that and the peritoneal vessels. And I'll go in this for the second time and mobilize lateral to the testes and the vas, leaving good amount of peritoneum on the vas to preserve the artery of the vas, and do the second stage of this Fowler Stevens.
Okay. So what are when you do these procedures, Fowler Stevens, and then these things, what are the risks they are carrying?
So the complications that can happen is there can be bleeding, intraoperative bleeding, and it might lead to atrophy of the testes in about 5% of the time, atrophy and subsequent loss. When you go in, might see a testicular remnant or atrophy. In that case, I might have to remove it. And then infection, bleeding, and complications related to anesthesia, access. Those are the things that can go wrong. And especially the pediatric anesthesia part is important.
All right. Okay. So can you explain what are the embryological things that happens with the undescended testes? Embryological basis of this.
Yeah. So up to about 6 weeks, the gonads are undifferentiated in either sex, And 6 to 7 weeks under the influence of SRY section, the formation of the testicle occurs. And then the descent of the testicle occurs in 2 phases. By about 12 weeks under the influence of mullerian inhibiting substance, the testis is coming to the deep inguinal region from the genital ridge. And then 25 to 30 weeks or so, under the influence of testosterone, the testis descends to the scrotal sac.
Yeah, thank you. The time is up. Thank you.
Okay.
Kanil sir, your feedback.
Yeah, I think the good thing I see also when he was given the topic, he keep on talking, and he talked in terms of percentages and all. That is good. I think that will add glamour to the presentation, isn't it? And so it looks like he knows about most of the things about descendant testis. So I think I would rather give him 6 or 7, isn't it?
Okay, sir. And I have noticed that Sanjay sir was not happy when he's saying testicular loss of 5% for Fowler-Stephen. So it must be 20% Fowler-Stephen. And normal okidopexy have a testicular loss of 5%, testicular atrophy, late testicular atrophy of 5%. And Fowler-Stephen have a testicular loss of 20%. Yeah, few questions to Sanjay sir. So when you do a stage 1 of Fowler-Stephen, when you will do the stage 2, sir? After how many?
Usually we would wait for at least 6 months. Yeah, 6 to 8 months, but 6 months is adequate. A few centers, I think I have heard that they do even after 4 months. But certainly, you know, there is no harm waiting 6 months, then everything would be healed and all this. And also, I think one little fact, so there is a single stage laparoscopic okidopexy where you wouldn't divide the vessels and then bring it down. But the Fowler-Stephen is always the clipping, in Fowler-Stephen, the vessels are clipped, but you wait for 6 months if it is a staged Fowler-Stephen. But single stage Fowler-Stephen is you clip the vessels and bring it down to the scrotum in the same setting. You don't do it in 2 different settings, and that's what you call the single stage Fowler-Stephen. And there the testicular loss is even higher.
Okay, sir. Yeah.
Only one procedure, but you carry a little higher risk of testicular loss.
During Fowler-Stephen, sir, how do you assess during laparoscopy whether this testis will come to the scrotum?
Yeah. So before you, now in a Fowler-Stephen procedure, you don't want to mobilize and disturb the gubernacular vessels and the artery to the vas, all those vessels. So because of that, so before mobilization, you have to decide, are you going to do a single stage laparoscopy where you're not going to divide the vessels? You just, so you are in that situation, you are relying only on the artery to the testicular artery and vein, and you are dividing all other, not vas, but gubernaculum, everything else. And you might even compromise a little bit on the artery to the, mobilize the vas. But in a Fowler-Stephen, you don't mobilize any of that. So you have to decide before mobilizing whether the vessels are long enough for that. So the trick that we do is you take the testicle that is hanging from the, like a mesochium, and then see whether the opposite deep inguinal ring can be touched without any mobilization. So if the opposite deep inguinal ring can be touched by the testicle without mobilization of anything, then you think that the artery to the, mobilizing, you can then, without dividing the vessels, you can bring it down to the scrotum. But
suppose, sir, the age of the child is 10 years and coming with undescended testes, will you do a okidopexy or will you go for okidectomy?
Yes, that's a very, very tricky question in the sense that, but from if you're just a very theoretical man, yes, you can do okidectomy after puberty, and because it's of very little function spermatogenically. But most of the time, the parents, you have to discuss this with the parents. So parents, and then what you do is you suggest to them that once the child achieves puberty, we will put a prosthesis and then maybe even revise the prosthesis to match the opposite testicle and all those things. But lots of the time, our parents will beg you not to throw away the testicle and do it, and then they will come for serial assessment of any subsequent malignancy and that sort of thing. So although it is non-functional, they would be happier with the prosthesis, their own one, if it can be brought down to the testicle, as opposed to a prosthesis. So there is no one single answer in my book, but you can certainly explain all the pros and cons to the parents, and parents will eventually decide whether they want
So in your practice, sir, what are the indication for okidectomy?
Okay, yeah, so that would be theoretically, yeah, so you would suggest to the parents that this testicle has no spermatogenesis function, so there is no, it will not add to the fertility. So because of that, it will only have a androgenic function, and then after puberty you can get rid of it, and then if they need, they can. Yeah.
So for the undescended testes, usually at what age, sir, you do the surgery? Is it 3 months, 6 months, 12 months?
We would be doing between 6 and 9 months, actually. Yeah. If the child comes to us, we would certainly be doing our best to schedule it definitely before the first birthday. But around 9 months is what I feel is the optimal time, particularly for a laparoscopic procedure. But the 6 month ones also do very well for some reason, in the sense that if it is a traditional okidectomy where there is the anesthetic risk is also minimal, then a 6 month one would be better if it is a palpable testicle. Impalpable ones also, I think, laparoscopy is not that difficult in a 6 month old, but the anesthetic risk would be slightly higher. So 9 months.
How frequently, sir, you see vanished testes? So when you do a laparoscopy, everything is blind and
so absent testes, yeah. So vanished one we would normally call what has been documented in the scrotum disappearing, but so absent testes is laparoscopically is quite common. I think when we do laparoscopy, about a third of them are there, third absent or anochia, and third the vessels are leaving the deep ring, and usually you have
So what was the reason, sir? Okay, 20% of the testes are undescended. Out of that, 1/3 is absent testes. What is the reason now we are not doing MRI scan, straight away going for a laparoscopy?
Because none of these tests, because there are quite a lot of false negatives, or you might see no testicle in the MRI, but then when you do a laparoscopy, so there is no single, where you would, because in this day and age of litigation, you would particularly if the child presents 10 years or 20 years later with a intraabdominal mass, which turns out to be a seminoma, or
and maybe other reason is they need anesthesia for MRI scan.
Yes, that's another problem. Yes, that as well. But certainly, only the MRI in certain centers probably that has specialized in this, or good machines and all kinds of things. Says that it has relatively, close to 100% accuracy. But in our situation, certainly it's not even close to.
So after the surgery, there is a risk of tumor, seminoma is a slight risk. Do you advise the mother to examine the testes or child to examine testes?
Yeah, but this risk is not when the child is, certainly it's more, the risk becomes apparent in the teens or late teens and a little older people. So there is no real need to make them so anxious about it when they are, to do it every 6 months or 1 year annual follow-ups are a little superfluous, I think. But certainly you mentioned that there is a problem like this, so that it's in their mind, but you certainly have to tell them that this risk is apparent only after the child reaches, puberty kind of age. So even after okidectomy or no okidectomy, the risk remains. And if, there is a school of thought that if you do it before 1 year, the risk of malignancy can be reduced slightly in the undescended testicle, but there is always a slightly higher risk in the opposite testicle, as in the brought down testicle, the okidectomy testicle also, despite the okidectomy. And so you discuss it with the parents, but then you start monitoring them probably in their teens and onwards, but certainly you will have to tell them that there is a risk. But that risk, no. So again, if they ask for percentage, it is only about 1 or 2% of the undescended testes that will undergo malignancy. So the great majority have no malignant risk. So, you know, what is the testicular malignancy in the adult population? About 1 in 10,000, is it adult per year, or 1 in?
Yeah.
So
but that is the testicular cancer is the common solid organ malignancy between 20 to 40 years, but it's not so common. Maybe 1 in 1,000. Yeah.
This is about 10 to 15 times commoner in the undescended testes. So
Yes.
if it is 1 in 10,000, then it becomes 1 in 1,000, or that is 0.1%, or maybe maximum of about 1% of the undescended testes will be malignant. So you have to tell that as well. Otherwise, you're just burdening these parents, and you know, because that's the thing that will, or everybody. Yeah, it has to be told, but you don't have to scare them unnecessarily, or as well.
Thank you, sir. The time to move to the next scenario. This is a fifth scenario, which will the examiner will be Sanjay sir, and the candidate will be Dr. Nalin. Nalin, Nalin is ready. So Sanjay sir and Dr. Nalin, the time start now.
Okay.
Good evening, sir.
Good evening. Good evening. Yeah. So this is a 14-year-old boy presenting with sudden onset pain over the left groin. So what goes through your mind, or what are you going to do?
So this is a urological or a surgical emergency. So in that case, I will attend the patient immediately and make sure that the patient is stable, and take a focused history and examination with the presence of a chaperone, because child is 14 years of age. And in my history, I will mainly concentrate on the onset of the symptoms, and whether there were any associated other symptoms as well, like low reflex symptoms preceding
only 5-year duration. Yeah, 5 hours. Yeah, just started 5 hours back. Sudden onset severe groin pain.
Yeah, so in that case, I will make the focused examination, the scrotum, whether it's unilateral or bilateral, and whether there's evidence of pain over the inguinal region as well. So with that, I have high suspicion to exclude testicular torsion, and the other differential would be to exclude epididymic orchitis. And in the history, I would also specifically ask about any history of trauma into the scrotum during the last few hours. So I can see on the examination, in the picture, there is a left-sided hemiscrotal edema with discoloration of the scrotal skin. So this is with the examination, unless proven otherwise, I would want to exclude a testicular torsion. So in that case, I would explain the procedure to the guardian as well as the child, because it's 14 years, for the necessity of emergency exploration of the testis and see the viability of the testis, and to fix it if it is viable. And at the same time, I would explain the guardian that if the other, even though the other testis is normal, we might need to fix the other testis if there's a rotation or the torsion of the testis on the left side. So with that, without waiting for any investigation, any imaging, I would take the patient to the theater with the consent from the patient as well as the guardian for an emergency exploration of the scrotum.
Okay. And if this child was 3-year-old, would that be different?
In that case, another differential.
Child, is a small child, yeah.
Yeah, in that case, I would have another differential, the idiopathic scrotal edema. That would be a benign condition. Apart from that, again, I would have
This is the patient, the 3-year-old, or let's say 2.5, 3-year-old. Do you consider idiopathic scrotal edema in this patient? Just look closely.
Not really, because there's scrotal edema, redness, and yeah. So it's grossly swollen. So idiopathic scrotal edema would not look like this. And other thing I would like to exclude is whether this is a obstructed descended hernia, because I can see that there is another lump on the left side as well, just above the testis. So anyways, I would consider torsion of the testis, epididymiocarditis.
So you said it's unlikely to be idiopathic scrotal edema because of what reason?
This is the I see it like the testis is swollen.
Okay, right side is swollen.
Yeah.
And left side you can see a slight swelling at the upper pole.
Yeah.
Okay. So yeah. So why was the idiopathic scrotal edema unlikely in this one? So because of in idiopathic scrotal edema, what would be the swelling like?
It would be extending into the groin, sir.
Yeah, it's going into the perineum, the groin area also, and also it will be symmetrical, and it would be involving both, you know, it will cover the two sides almost symmetrically. You see, now this is very lateralized, no?
Unilateral, yeah.
So that's unlikely in, you know, it's not impossible, but it's unlikely in idiopathic scrotal edema. What we would say 99% of the time, it's sort of symmetrically everywhere. It's enlarged and also even spreading onto the skin of the perineum, the pubis, that area also. Yeah. Okay. And now say if this is unilateral lesion, so what, you know, now if you are a betting man, like percentages wise, a 3-year-old having a torsion is more likely or less likely?
It is less likely because the torsion.
So, yeah. So what is the more preferred, you know, top on the differential diagnosis? What is it?
I would go for epididymiocarditis.
Okay, epididymiocarditis. Anything else?
And then torsion of the appendix of testis, but it is unlikely in this case.
Why?
Because the edema is, I mean, it involves the whole scrotum.
Yeah, too much erythema. Okay, yeah. But suppose if you look, you know, if you forget about the right testicle, if you just look at the left testicle, which is quite tender in that upper pole area, yeah, so that might pass off like a little, particularly if it looked a little blue, yeah. So, so what are the other differential diagnoses in this, you know, when you have acute scrotum in a 14-year-old, what else is possible? So testicular torsion high on the list, and you know,
then,
so, yeah.
Then the epididymiocarditis, and then comes the testicular trauma causing hematoma.
Okay.
And then that I think we could have excluded with history. And the other possibility would be testicular cancer, but it is unlikely in a 14-year-old comparatively, because it's more common at the age of 20s and 30s.
Any malignancy that's that is possible in a 13-year-old?
That does not come into my mind, sir.
So hematological malignancies, leukemia, leukemic infiltration of the testes. Yes, that's what it is. You know, if you have the different diagnosis list in a book, that would say tumor, but that is not seminoma or teratoma, but it is more hematological, you know, leukemic deposits in the testes. Yeah. Okay. So anything else?
Apart from that,
picture, I can't find it now. So anyway, so if we had you know, I lost it. But say if there was a leg, you know, some, you know, like a skin rash, the parents was, you know, showing you the legs of this child, and he has a skin rash on the legs. Does that ring a bell?
I think then the lymphedema and lymphangitis also comes into the picture.
So you mean the scrotal swelling due to lymphedema?
Lymphangitis probably. not lymphedema.
Okay, okay.
Uh,
Anything else? A petechial rash on the leg?
I can't think of a diagnosis.
Purpuric rash? A purpuric
Yeah.
rash? Hinoxon lane purpura?
Yeah.
So they get scrotal swelling and pain, just like actually a torsion. There have been 1 or 2 cases, each year that we, if particularly when we explore the testicle purely on, if you, as you said quite rightly, if you explore the testicle, anybody coming within 6 hours should go to the theater as quickly as possible. But it's important that you look at their limb, so HSP needs to be excluded also, because that, so it happens. So you certainly advise, inform the parents that there is a chance that they might end up with a negative testicle exploration, but so you're going to take him there. But HSP is a famous example of testicle will be pretty much normal, non-torted, but will have very similar or identical things to this one. Forgotten, you can anyway. Anything else that you, so if you now say, if this patient's mother told you that this patient gives a history of trauma to the left groin also, few, immediately prior to this episode, what would it change your management, or you would go ahead with your exploration?
Still, at that point also, my differential diagnosis, on top of my differential diagnosis, I would want to exclude a testicular rupture and a hematocele. So in that case also, even so, because of the time period, 5 hours had gone, I would consider exploring the scrotum and the testes.
Okay. If you have an on-site radiologist?
In that case, without delaying the exploration, I would go for a testicular or a scrotal ultrasound scan. In that, I would like to see whether the tunica albuginea or the testis appears normal, whether there's evidence of rupture, and whether there's evidence of hematocele or hematoma surrounding this testis. And also, they would give us an idea about how the vasculature of the testis is. But that will not exclude acute testicular torsion, because in the initial stages, there will be, in the initial stages of the venous obstruction, there will be evidence of arterial supply to the testis, even if it is a torsion, early torsion.
And so, and also, do you think that the injury may have predisposed to a torsion as well? I mean, so it may not be just a coincidental minor trauma, because lots of children will have 1 or 2 traumatic episodes every day, either a fall or a little, fight with the siblings or friends, and so it's a pretty common occurrence. Yeah. So, and also now, if there are, do you have a different age group? Say, if there is a 1-month-old baby coming with probably not a painful testis, but a swollen testis, what would you think of that?
In that case, I would have the differential of testicular torsion, but more towards the torsion of the appendix testis would come more forward in the differential diagnosis.
A neonate? Yeah. Is there a different type of torsion in them?
Time's up, sir.
Time up?
Time's up, sir. So I think sir is asking an important question, Nalin. The management is a different, the anatomy is different in a neonatal torsion and adolescent torsion. Maybe sir is asking about that. One is intravaginal, other one is a extravaginal torsion. And so, yeah, sir, first give the feedback, then we can ask the question, sir.
Yeah, I think probably 5+.
Okay, sir. So So how do you manage the neonatal torsion, sir? Will you operate or will you wait and see or conservatively manage?
No, we generally, I personally recommend that we explore the testicle, confirm that it's a neonatal torsion. And usually if it is, usually they are almost always non-salvageable, some of them intrauterine or perinatal events. So very rarely can you salvage that testicle, but if it is completely dead, then we would actually remove it. And we would look at the opposite testicle also. We had, actually we did a case report also. It's a child who came with a one-sided testicle, which was like a stone dead. And then the opposite testicle was also torted, just like a maybe 180 degree, but fortunately was just a little congested, but we could salvage it. So that since that experience, we always explore neonatal torsions, fix the opposite, and then
so
take it
usually, sir, up to how many hours you go for exploration? Is it 24 hours?
Neonatal or neonatal?
No, adolescent and everyone.
Yes. So we would actually explore, of course, that urgency becomes a little less if it is been there convincingly 24 hours. But only thing is that occasionally we have found that period, even once we had a child actually coming to us with a 24-hour duration episode, because we routinely explore all acute scrotums, we managed to salvage it because it was only a maybe 180 to 270 degree, because torsion, if it is just a one twist, might not completely make the testicle gangrenous. But so yeah, I think I generally, particularly for teaching purposes, I generally explore all my testicles, and then if it is gangrenous, we would remove them.
And all the testes, sir, they rotate towards the midline.
Yes. So detorsion is usually an open book, opening of a book kind of thing, but that not always. I think there is a percentage it's in the opposite direction also. That's the main reason why sometimes if you by detorting, you might make the twist a little more also. So we never do detortion in children because it's impossible to even feel the testicles, or let alone try to detort it without GA. So if it is GA, then might as well explore it. So, but
when you put an incision, sir, when you put a midline incision, or
yes, midline, we put a scrotal raphe incision, midline incision. Yes.
Even if a late presentation, you go for a midline incision.
Yeah, because we find it easier to explore the other side. Because cosmetically, whatever incision doesn't make a difference because it's almost invisible. All scars on most scars on the scrotum until they get infected.
So fixation, you use nylon or Vicryl, sir?
No, we always use a non-absorbable proline. Yeah, we use proline, fine proline. We use a pyoproline actually, but so I think the recommended one, I think all over, would be using a non-absorbable material for if you want to, because once it absorbs, especially if it is left inside the tunica, then it probably will have the same. It might tort. I don't think it will cause sufficient.
Now, so suppose the examiner is saying the child had a previous exploration and fixation. Now again coming with the acute scrotum. What you will do? So what is your answer, sir?
That will be you look at the op note and see who has done it actually. So that's one thing. But yeah, I think so in literature, there is always cases of torsion in previously okidopexied testicles. So it doesn't exclude torsion. Yes.
So the 3-point fixation, sir, what are the 3 points you fix?
We fix, we actually sometimes, if it is particularly a viable testicle, we fix it on the medial aspect in a single stitch, like a square stitch going across the scrotal raphe. And then on the lateral aspect, so we take 4 point, I take 1 point as the spermatic pole. So that's fixing it as well. Now, upper pole is more or less fixed. So we use the lower pole, medial and lateral. So you see now the bell clapper also, now it has the upper pole is fixed by the spermatic cord. So,
Suppose, sir, if it's a blue testis, but when you think it's a doubtful testis,
yes,
but you are in a two mind whether to just leave it or to do a okidectomy.
yeah.
And do you
in
do
those
a
doubtful
incision of
ones,
the
what we do
capsule?
is now, yeah, we do a, like a, what do you call the we take it like a compartment syndrome. So if you think that there is sufficient evidence that it has revascularized or reperfused within 10 minutes, and maybe if you make a little incision on the tunica, if it bleeds actively, then you can like do a fasciotomy, like you do fasciotomy for your calf ischemia. So we release the tunica albuginea and then cover it with a little patch, oval patch to release it. And then people have shown that, particularly those that come between, 12 to 24 hour ischemia, quite a lot of testicular salvage, at least, they're not 100% sure how much of it is functional, but certainly the testicle, there may be a palpable testicle in the scrotum with that kind of approach. Yeah. So there is.
Do you believe the theory of anti-sperm antibodies, sir?
I mean, so the sperm, spermatogenesis itself starts at puberty or thereabout. So in a say if it is somebody is younger than puberty, certainly there is no spermatozoa to cause antibodies, I think. So people believe that under 10-year-olds, so that doesn't really come into practice, but so there is this theoretically, I mean, we don't do antibodies and things like that to kind of practice, but yeah, I suppose the theory behind it is that these blood testicle barrier, isn't it? Yeah, so that also is developing in normally after puberty, is that right? Blood testicular barrier, I've read that it is not there when they are pre-pubertal. Testicles don't have a blood testicular barrier in any case. Okay, so, right. But only thing is now these, lots of them are around puberty or post-puberty, so torsions. So in them there is a theoretical question, but I'm not aware of.
Okay, sir. Suppose if you are doing a okidectomy, sir, will you do a primary prosthesis, or you will wait and later you will put the prosthesis?
Yeah, in our situation, we generally wait for puberty. We generally offer, because if you want to do it as a small child, then you have to revise the prosthesis very often. And when we do it, we would put one size above the opposite testicle, and then this thing. But most parents that I've encountered prefer to wait till the child is old enough to decide for himself and then have the prosthesis. Actually, very few of our parents opt for a thing as a child. Yeah. So in our practice, it's very rare.
Thank you, sir.
Insert the prosthesis.
So yeah, you have correctly mentioned about the HSP, the Kinoshal purpura, and the idiopathic spot edema. There is also a very important differential diagnosis. I think we are moving to the last scenario. The time is flying. The last scenario, the examiner will be Dr. Kanjana sir, and the candidate will be Dr. Nishanta Lienapatrana. Dr. Nishanta and Dr. Kanjana.
Hi, can you hear me?
Hi, sir. Yes.
Yeah. So, right, okay. So I'm going to ask you, give you a scenario. It is a 7-month-old girl presents with a pyelonephritis. She is admitted under the pediatrician and respond well to the antibiotics. She has a USS finding before discharge, which shows unilateral hydronephrosis, right? So what do you think about this patient?
Yeah, 7-month-old child with a clinically suggestive of pyelonephritis. So I think this is one of the atypical UTIs at this age. So I would assume around about 40% of children with UTI would have a congenital anomaly. And then out of that, about 70% will be vesico-ureteric reflux. So when hydronephrosis on single side, one of my suspicion would be a vesico-ureteric reflux. But at the same time, there are other conditions which I would like to consider, which is like a megaireter, which is either refluxing or non-refluxing. And then, yeah, those are the two things which I would like to consider.
Okay. So how do you proceed from here? So now you have a suspicion of a either megaireter or a reflux. So what would you do now?
Yeah, so at this point, once the child is being treated, I would like to arrange further investigations in view of DMSA scan. So I would like to go for the top-down approach, so to detect whether there are any scarring on the DMSA scan, and then at the same time, I would like to assess the sleep function, but I would like to wait for a while after pyelonephritis for the DMSA, because the imaging will not be very adequate for the sleep function. Then I would arrange a micturating cystourethrogram to rule out whether there are any VU reflux of this child.
All right. So how do you classify the VU reflux?
VU reflux can be classified according to the International Reflux Group recommendation into 5 categories. So grade 1, which is just contrast in the ureter. Grade 2 is contrast in the ureter and the pelvis. Grade 3 is both ureter and the pelvis and the mild degree of dilatation. Grade 4 is moderate degree of dilatation, and grade 5 is the severe dilatation of the calyceal and pelvic, as well as the ureter with a tortuosity of the ureter.
So you said about the DMSA scan, isn't it? So what information you can gather, and if you suspect a renal pathology there, where do you expect that pathology?
DMSA scan would actually detect any scarring, and then when there is a scarring, DMSA will show a non-uptake areas, which will sort of give us some anatomical details of the kidney, about the functional details of the kidney with the scarring.
All right. Okay. So so now you with these both tests, you have diagnosed the patient has got a VU reflux, most probably grade 2 or 3. And then what is your next options? How are you going to follow this baby up?
Yeah. So when the child is diagnosed with VU reflux and she's had one episode of pyelonephritis, so I would like to manage this child with a few approaches. Number one is the sort of disease education about the parents and the importance of treating a UTI, a symptomatic UTI, and detection and those aspects, as well as the about the prevention of the UTIs in this child, especially advice on the fluid intake and the bladder bowel care and the cleaning and all. Then the most important aspect is the continuous prophylaxis antibiotics. So I would like to consider putting the child on prophylaxis, and then see whether she's getting a breakthrough infections with that.
So how long are you going to give her prophylactic antibiotic?
I would like to give prophylactic antibiotics at least for about 5 years, and then at the same time, I would like to regularly follow her up with ultrasound scans, to see whether she's sort of deteriorating on the reflux pattern or the grade.
All right. So what are the indications if you happen to propose a surgical intervention for this patient?
Surgical interventions are like should be considered in a step ladder pattern. So if the child is getting breakthrough infections while on antibiotics, then the next step we could recommend is to go for endotherapy. Endotherapy includes injection of bulking agents. So there are a couple of bulking agents, either Teflon or copolymer hyaluronic acid. So, so we could recommend the endotherapy as the initial stage. There are a couple of studies also which sort of recommends endotherapy, efficacy of the endotherapy around about 75% success rate in the first treatment and about 85% success rate in the second treatment. So this can be given as a hydrodistension and injection therapy. Then if the child is getting furthermore episodes of breakthrough infections, then we can consider about the surgical therapy. So there are a couple of surgical therapies, including extravesical and intravesical type of ureteric implantation. So extravesical includes Gregoria, and then intravesical reimplantation includes cross-trigonal Cohen's for Ledbetter-Politano reimplantation techniques.
Okay, so what do you think the embryological defects behind this reflux? Or what are the causes for reflux in ureters?
Yeah, there are a couple of theories for reflux disease. Mainly, there is a concept of Parkman's law, which suggests that the suburothelial ureter or submucosal part of the ureter should be 5 times the diameter of the ureter. So if the ratio is changed, there is a chance of reflux. And that particular way that the when the bladder distends, it will keep the ureters sort of more of a compressed. And also there are some myogenic theories, which includes sometimes the circular muscle tone, as well as the longitudinal muscle attachment of the lower ureter to the detrusor, will also act as a sort of reflux preventive mechanism. And that is for the primary VUR, and there is another category called secondary VUR, which is due to the high intravesical pressure, like in the posterior urethral valve. So in those instances, basically the increased intravesical pressure, which will cause the reflux disease.
So you were talking about a few other causes. So if it is a male child, what are the thoughts when you see, if you happen to see a boy with a pyelonephritis and hydronephrosis? What are the things that you would think?
Yeah, I would consider one of my other possibilities, a posterior urethral valve. So which is again could be unilateral for about 14%, but usually it's bilateral and more severe, which presents with early age than this. But to rule out that also, I would like to investigate with MCUG early.
Yeah, thank you, Dr. Nishant and Dr. Kanchana. Thank you. Time is up.
Thank you.
Yeah, okay, I think he's well prepared, isn't it? So probably will give him a 7+ or something like that, isn't it?
Yeah, even 8 is okay for him. Yeah, he did.
Yeah.
So Sanjay sir, any input, sir, regarding the VUR and the recurrent UTI?
I think, yeah, so what you need to know is that it is a condition where surgery is probably the last resort and certainly not the first option. So, and
sir,
also,
do you give deflux, sir, or the endotherapy you give? But
that's the thing, yeah. So Reflux is not available because it's not registered here. And when we met at one of these WOFAPs, that's the World Federation of Pediatric Surgery, we had a meeting in Qatar last 2 years back, and we met the guy who is the, the American chap who is, he said that he certainly can make it available here, but then first thing is for us to have the registration, and of course the cost is about $1,000 per person, I think. So it's prohibitively expensive. So the dollar has gone up so much, so that at that time it kind of, we felt it is about 1.5 lakhs. Now it's probably more than 2.5 lakhs, I suppose. So that makes it very unattractive to us. So that's the main reason, because that's the only thing that now Teflon is no longer used. So
because of the Birmingham reflux study have compared the medical management plus reimplantation, they said both same.
Yeah.
And the Swedish trial compared the endotherapy plus antibiotic plus observation, and they have said the antibiotic and endoscopies are better rather than surveillance. So and so I think that
so certainly, grade 1 and 2, the antibiotic prophylaxis, if the parents are compliant, is definitely, so that's what we do. We have only 2 classes, grade 1 to 5 is irrelevant for us. So we have 1 and 5, so all of 1, 2, 3 is more or less the same. So we all on prophylaxis, and then there is a breakthrough infection or scarring of the new scars on DMSA on subsequent, sometimes the infection is not recognized by the parents. So if they have new scars, then there is a rethinking, like, okay, does he need a procedure to prevent reflux? But certainly, so the first grade 1 to 3, certainly we have, I don't think we've done, so for the last 1 year, we have done maybe 1 or 2 replantation procedures, and that too is mainly for demonstration sometimes. And real.
So it's going out. Yeah.
Are you injecting fat, dissolved fat or something?
Yes. The other issue is that now when we were at this urology meeting, one of the guys who was a pioneer in US who was promoting it said that there were cases of ureteric stenosis, 10-15 years later, and even young adults coming with stricturing following. So he gave a nice, Professor Ransley, Great Ormond Street, one famous pediatric urologist from Great Ormond Street, he said, he gave a nice, but I don't forget it, everybody came up, there was a loud laughter from the audience. He said they have paid so much for, so little, and more than that, they ended up, losing their kidneys, some of them. Yeah, so it was like that. Prem Puri, one of the proponents, or the one who pioneered in UK or Ireland. So he, of course, came for one of those urology conferences we had with the SARC Association of Pediatric Surgeons. And of course, he was all for it. So, but I think the world opinion is that grade 1, 2, 3, you almost never need surgery, and so is endotherapy as well, I think. So it's time has given the final verdict.
Yeah. So, thank you, sir. That was a very excellent 6 case scenarios, and I think that there are our candidates want to ask few more questions from the examiners. Guys, we can ask any question from Dr. Sanjay sir and Dr. Kanjana sir. If you have any doubts you want to clear up.
Regarding Sanjay said, antenatal hydronephrosis, you were asking about antenatal interventions.
Yeah. Yeah. So you would like to know what? Yeah. So interventions are, people have, on an experimental setting. So nobody in the world does it for as a practice in some center in California, and I think mainly in US does it on experimental, did it on experimental basis. The open pyeloplasty through the uterotomy, I think, yeah, through, delivered the baby through in, I think, the third trimester, and then did a pyeloplasty and then put it back, sutured it together. But lots of them ended up going into early labor and a lot of complications. So they have given up that practice even as an experimental procedure. But then few other endopyelotomies and things like that are practiced as an experimental, on an experimental basis. But so you simply can discount the parents' suggestion that in our, and it is unlikely that they'll be able to get even a broad antenatal procedure.
Even for the posterior urethral valves, sir, they
PUL
have attempted.
is a different matter. Yeah, PUL is a different matter. So there you would can do a what you call a vesicoamniotic shunt procedure. But in our situation, so that's all done by the interventional fetal medicine, obstetricians with that experience. But we have had 1 or 2 babies coming in with the shunt, but most of them have got dislodged or may have been impositioned. So they were all in the peritoneum. So we are following up these patients. Our nephrologists are sending them frequently, asking us whether we can remove that shunt and all that. But it's all in the retroperitoneum, or it's got dislodged into, some of them may be in the mother, but what we end up is the shunt in nowhere, and then
But they have more risk of miscarriage as well, isn't it, sir? That this
I think so. Yes, all these procedures induce preterm labor or induce labor, so that's always a problem. Yes, so for any procedure. But
and there was a few numbers. I think 10 or 20. They did the posterior PUV ablation during the fetal life. But that they have confirmed it's not useful because more miscarriage and things. But as you said, maybe the shunt may be
is to preserve the antenatal, to prevent antenatal renal dysplasia, because that is the real killer. So PUL is a common problem, and lots of them end up with the renal replacement therapy later in life. So to avoid that, the only way is to prevent antenatal renal dysplasia. So because even if we relieve the pressure with the ablation, vesicostomy, ureterostomy, the pre-existing damage is so much that they go on developing renal failure subsequently. So to avoid that, people do use, I think, as a therapeutic procedure in lots of centers, I think UK, US, this shunting. But there are disadvantages, but it's not practiced in our situation because I think you need more and more fetal medicine specialists doing them frequently and being trained for that. But I haven't seen anyone successfully decompressing it yet.
Okay, thank you, sir. Any other questions, candidates?
Sanjay sir, Suranga here.
Yes, Suranga.
So in posterior urethral valve, in which occasion we are going to do a vesicostomy or bilateral uretero?
Yes. So always we try to do a PUL ablation initially. If it is a child who is less than about 2 kg or 2.5 kg, sometimes our cystoscope, which is French 7.5, is not negotiable through the urethra. So in that situation, primarily you might be tempted to do a vesicostomy, especially if the renal function is not improving with the, so you try a urethral catheter and wait for a week or 2. And obviously you go to MCUG in the meantime and confirm the diagnosis. And then like your ureter extends, that will open up the ureter. So your subsequent ureteroscopies, I heard that, I've seen that the double J stents facilitate a subsequent ureteroscopy insertion. Is that right? Having a, yeah. So similarly, I think when we have the urethral catheter, we use not Foley catheters, but feeding tubes, infant feeding tubes, which is French 5 usually, in the catheter, in the urethra, and that helps to, we even recently, last week or 2 weeks back, we had a child whom we thought we might not be able to pass the cystoscope, but then when the baby was 2 weeks on catheter, the renal function improved on the catheter, and then we did a successful PUL ablation. He's still, on the nephrology follow-up, still in the hospital because the blood urea creatinine has come down, but still not normal, and potassium is a bit high. But so because of that, the first line is PUL ablation, but then if the ablation, despite ablation, if the creatinine is rising and if the upper tract dilatations are persisting, then you would wonder whether, and also the urine flow is not great, then you would do a vesicostomy. But if the vesicostomy does not improve, or if you feel that the ablation is sufficient and then the obstruction is like a functional obstruction at the VU junction level, then you would go for a ureterostomy, because lots of these patients have gallbladder, particularly when they come later on, like say you relieve obstruction, they improve, but then subsequently they continue to have severe hydronephrosis at the ureter, as well as their renal function remains elevated, or their creatinines remain elevated, they're hyperkalemic and problems, then you might have to decompress it because there is functional obstruction at the VUJ level. So in that situation, you will have to go for a ureterostomy to decompress the ureters completely or kidneys completely and see whether the renal functions improve. If that is, if still the renal functions are not improving, that means there is a very severe dysplasia because of the antenatal pressures. So that is basically what determines it. So this functional VUJ obstruction is a great concern. Yes.
Yeah. Any other question?
Okay. Thank you, sir.
So regarding the ureteric reimplantation technique, what are the ureteric reimplantation techniques you suggest for pediatric?
As discussed earlier, so if there is bilateral reflux, then the preferred option is a trans-trigonal, the Cohen intravesical technique. So you mobilize the ureters, then reimplant them trans-trigonal. And if it's a unilateral one, sometimes particularly if there is a mega ureter as well, so you would like to taper it and then put it on, and if the other ureter is completely normal, because the trans-trigonal one, if you do a unilateral reimplantation, the chance of causing reflux on the other side because of the dissection in the opposite direction is a bit high. So I generally prefer unilateral one, particularly with a mega ureter or big ureter, grade 5 reflux that needs probably tapering, then a Ledbetter Politano kind of procedure is preferable.
Right. Thank you, sir.
So,
okay.
Yeah.
Any other questions?
Say in absent testicle, when you explore for an absent testicle,
impalpable, you mean impalpable testes, isn't it?
Yeah, impalpable testes, you do the laparoscopy.
Yeah.
And the testes, say the testes is not there.
Yeah.
And will you be okidopexing the normal side?
You mean fix the opposite testicle?
Yeah, yeah.
So the main reason behind fixing the opposite testicle in torsion is that usually the 90% or very high percentage of testicular torsions are due to an anomaly, the bell clapper anomaly. There is high investment, which is found to be, about 50% bilateral, quite a number, not 100% bilateral, but in the cadaveric studies and in dissecting bodies, they have found that bell clapper anomaly is not always, but bilateral in a fair number. So that's the reason why you would do a fixation. So in that situation, but so in an undescended testicle, that risk is not there. So the opposite testicle may be normally positioned and normally fixed. So there is no inherent risk of torsion in that opposite testicle. So on that count, it doesn't need a fixation. But so it's like there are certain there is a certain group of pediatric surgeons and urologists who thinks that, okay, now this is a very valuable asset. So if you lose that for some reason, there is a issue. So they will fix it just simply to prevent a possible torsion that maybe, that he may have a predisposing factor, like for a torsion. That's the only thing that is prevented in that situation. Or say if it is a trauma or any other cause of testicular loss is not prevented by that. So you can argue for both ways. So if you know the correct reason, then in an exam point of view, certainly. But yeah, so we, because losing that testicle is now losing one testicle is only loss of 10% function, but losing both is 100%. So there is all or nothing. So there is no harm in fixing that if the parents agree and if you also believe in it. Yeah. So there is 50%. There is not all agree, but yes, there is quite a large number of population of surgeons would fix or offer the fixation. Yes.
Yeah. Thank you, sir. Any other questions?
The 10-year-old undescended testis, boy with undescended testis.
Yes.
Probably that testis, fertility-wise, it's not functioning. What about the endocrine part of the testis?
Yeah. So that's why some people now, if they encounter 10-year-old is a undescended testicle, so they would offer the option to the parents: are you going for okidectomy or? And then because you need a real big surge of testosterone around puberty, that for that people think that both testicles would contribute. So in that situation, you would do the okidectomy once the puberty is established. But so because there is no harm waiting that year, I mean, he's not going to get a malignancy with the secondary during that time. So I generally offer that option, and then would do the okidectomy after puberty, and then hand it over to the endocrinologist. I mean, they will decide whether they need continual androgen support or usually not, I think, yes, because one is enough for the rest of the life. But those that say, no, we don't want to part with the testicle, somehow do the okidopexy, the parents will, if the parents insist on that, we would do it. And of course, they will have to be on the lookout for a malignancy, in 1 or 2% of the children that it happened. So that's the situation. I don't think apart, I mean, the malignancy, lots of people do take more than 1% risk in a lot of things that they do. So it's up to them, I think. Yes, I personally feel that it's the parents and then the subsequent result. But I recently encountered a young boy from a leading school, a Rhabdoid. He opted for the okidectomy straight away. So he said he will wait for puberty. He was in the puberty, I think, at that time. But then he came, he said he finished his O-levels and come, and then we did the okidectomy, because I offered, there is this option of auto implantation, where our plastic surgeons have done that once to patients. If the testicle is very high, they would rake it off and then turn the inferior epigastric artery downwards and then put the testicle in the scrotum and do a microvascular anastomosis. And so it ends up in the scrotum very well. Lots of these big children, intra-abdominal testes are impossible to be brought down into the scrotum, to have a cosmetically acceptable symmetrical testes. So they, if at all, will be high scrotal, because it's such a long distance now. So that's the other advantage of doing okidopexy in a very small child. You have smaller distance to travel, and these vessels are a little farther. So they actually, lots of our okidopexys that are done at 6 months are almost invisible. Subsequently, the groin crease incision also disappears. Scrotal incision, of course, doesn't exist. So they are just like normal people, very, very normal mobile testes with cremasteric reflex also, lots of them. So that's, so bigger patients, that's the situation.
I think if more question, I think we can discuss later. Thank you, Sanjay sir and Dr. Kanya sir. It was a very busy day for them. And once we asked to help, they have readily agreed and prepared a very good scenarios. I think candidates have to prepare the more scenarios on hypospadias, and other one is regarding phimosis and things. We couldn't discuss a lot. And on behalf of trainees, I asked Dr. Nishantha to thanks our examiners.
Neuropathic bladder also will be a, all of the things that are, neuropathic bladder, the continence, procedures, neurogenic, neurogenic.
And nocturnal enuresis. I asked about nocturnal enuresis and incontinence. Yes. Dr. Nishantha.
Extrophy, epispadias, complex kind of thing, are they relevant to the?
Hypospadias is relevant, sir. Yeah.
But extrophy may be too.
Things.
Yeah. Okay.
Dr. Nishantha.
Yeah, I think we had an excellent sessions today, and I would like to sort of thank Dr. Kanchana and Dr. Sanjay Begunsekara for a wonderful sort of scenarios. And I think many of us, as we are more familiar with the adult urology practice, we have some practical questions as always. And I'm very, very grateful for both Dr. Kanchana Singh and Dr. Sanjay Begunsekara for their time and valuable input in making these scenarios and helping our candidates for the exam. Thank you so much, sir. And also I would like to especially thank Dr. Balagobi. He's been the live wire, so arranging everything and doing quite a lot of work on behalf of the scouts and the trainers. Thank you so much, Balagobi.
Okay, thank you very much. Thank you for inviting. Yes.
Thank you.
Thank you.
Thank you, Ananda sir.
Thank you.
Thank you. Good night.
Yes.
Thank you.
Bye.
Good night.
Thank you.